My name is Joshua Levy. I'm one of the rhinologists here at Emory, and I'm really excited the opportunity to kind of share our experience and my thoughts on smell and taste as a primary symptom of SARS-CoV-2. So let's just jump straight in here. There we go. This is an example of the best newspaper art I've ever seen. It is an article that is published in April, I believe. March in South Korea, and it is one of the first reports of smell and taste dysfunction amongst patients with COVID-19. In this study, they evaluated just over 3,000 known COVID-positive patients with mild symptoms. They were healthy enough to be self-quarantined and treated symptomatically at home. Of this cohort, over 15% expressed symptoms of smell or taste loss. What was most surprising, I think, to all of us is that the majority were in their 20s. This is a young, otherwise healthy population, and 92% reported otherwise mild symptoms. This is when we first started thinking about the asymptomatic carrier and smell and taste as a potential biomarker for COVID. This was replicated in an external cohort. This is a research letter from JAMA that surveyed 200 Italian patients, a very similar population with otherwise mild symptoms of disease. In this population, over 64% reported an alteration of taste and smell. And again, this is often with mild or otherwise asymptomatic disease. Beyond South Korea and Italy, we're also seeing this here in Atlanta. One of the first groups of patients that were diagnosed with COVID was at Grady in March. And this was in a group of providers who returned from international work abroad, all of whom complained of a disturbance in smell and taste, all of whom turned out to, in fact, be carrying COVID. Following month at the emergency department in Midtown, there's an 18-year-old patient who presented with an isolated complaint of infectious loss of smell. She was not worried about COVID whatsoever, but was aware that one of her friends also had similar symptoms, and they had gotten coffee together a few days before she came down with these symptoms. So we're a little bit behind the ball. You know, all of these reports and studies are being published well after COVID has been declared a pandemic. However, we're now catching up. This is a statement from the American Academy of Otolaryngology, which essentially states that anosmia, hyposmia, alterations of smell and taste are considered primary symptoms of COVID, and we should thus treat new onset symptoms as COVID until proven otherwise. Now, there is some good here, and this is from a study that has not yet been published. However, it is a follow-up of the cohort in Italy that was published in JAMA. These patients were surveyed 4 weeks after their initial diagnosis, and shockingly, 89% reported improved symptoms. Almost half reported complete resolution of altered sense of smell and taste. Now, this is very different than what we would expect in other viral sources of olfactory dysfunction. The improvement rate lifetime is usually in the order of 40 to 60%. So the fact that we see almost 90% of COVID patients recovering their sense of smell is really quite encouraging. However, I was asked to write a commentary on that article, which is the only reason that I had access to share the data with you. And even though we have a huge rate of therapeutic response or patients recovering their sense of smell, just the sheer size of this pandemic really represents a coming deluge of number of patients likely to present to both mine as well as your clinics asking for help with their sense of smell. You know, if we take from May 7th, there were 1.2 million Americans diagnosed with COVID-19. If only 60% of those present with altered sense of smell or taste, which is consistent with the JAMA article, and then 90% recover, that still leaves us with 72,000 patients in America alone with a growth of 1,500 a day. This is the exact reason I was really pleased with the invitation to speak with you all today, and hope to help as we all manage these challenging patients. You know, my personal evaluation really hinges on history, especially now in the COVID era. Nasal endoscopy and smell testing, you both see starred here, and that's because they're tests that I consider in a routine clinic before COVID. However, given the risk of nasal endoscopy with disease transmission, it's considered one of the highest risk procedures you can do up there with intubation. It's something that we just simply are not doing currently. We reserve it for emergent situations. Smell testing, which here is an example of the smell identification test, also known as the UPSET, University of Pennsylvania test. This is a great tool to help us monitor treatment responses over time and also to sort out patients that may be malingering. This is a scratch and sniff test with a forced response. So in a patient with no sense of smell, we still expect them to get 1 out of 4 correct, so 25% correct response. Patients who are malingering obviously will get 0. They can identify the smells and are intentionally selecting otherwise. We do not use this routinely only because it's the history really that is most important for diagnosing sense of smell. This test is very helpful in quantifying the severity and then the treatment response over time. It's available from Sensonics and it takes about 10 minutes for the patients to complete in clinic. Imaging is not required for post-infectious loss of smell or taste. I will order a CT scan if it's indicated for persistent sinonasal disease, chronic sinusitis being the second most common cause of smell loss after post-viral or post-infectious causes. And MRI, I will only consider if there's additional central findings or if we want to complete the test to confirm congenital loss of smell. So the treatment for these patients, the first 3 I currently consider as first-line therapies. Nasal saline irrigations and topical corticosteroids, just about everyone gets that comes into my door with a sinus complaint. Both of these are aimed at decreasing the sinonasal inflammation that may be associated with loss of smell. Both are incredibly safe and well tolerated. Olfactory training is an intervention that previously I would not use as often as I am now. However, it again is very safe. It can be done via socially distanced approaches, and there's gaining evidence of efficacy over time. The corticosteroid taper, again, I have a star here, is something that I previously would use much more frequently than I am now in the COVID era, only out of an extreme amount of caution with studies of intubated, extremely ill patients with COVID having a higher mortality rate. As far as I'm aware, there are no studies looking at the safety of oral corticosteroids in otherwise mild COVID disease. So olfactory training, just a quick summary. This is a exposure repeated procedure that a patient can do at their home using essential oils. We recommend that our patients go to Amazon, and there are as many as they would like to experiment with. The goal is to awaken or reprogram neuroplastic receptors to rewire the sense of smell. To do this, the patients will stimulate their sense of smell with robust odors. We recommend 4 separate essential oils. Repeat this exposure 2 to 4 times daily. More seems better. The longer they do this, the better the outcome. And unfortunately, the mechanism of improvement is unknown. It's a bit of a mystery, and part of the reason that we don't have specific protocols for me to offer today. This is the findings of a meta-analysis that was done about 4 years ago. So there is some newer data, which has all been supportive. On the top here in this forest plot, we see the outcomes of infectious, so COVID-like viral illnesses, which do include coronavirus. And we see only 2 studies were done at this time. This one showing a high improvement rate, and this one less certain. Traumatic sources of smell loss and Parkinson's both have more certain positive outcomes in their studies. So as I mentioned, this is something that needs more study. However, what is available has been supportive and is the reason at this time that I'm offering it to all patients that I see with COVID-related loss of smell. So my recommendations is to treat new onset smell disturbance as COVID and self-isolate. Do not perform high-risk procedures. Avoid corticosteroids at the moment. And I would refer to otolaryngology with waxing and waning symptoms. This is much more significant or associated with chronic sinus disease or other concerns for CRS. And of course, with any questions, anything I can do, please don't hesitate. I'm more than happy to continue to work with you all and love to hear your experiences in the future. Thank you.
All right. Thank you very much, Dr. Levy. Let's see. Am I off mute? Can you hear me?
I do. I hear you.
Perfect. So I'm going to go ahead and share my screen. And with that, we'll go to the second part, of the presentation. I think we'll do questions offline just for sake of time. Let's see if I can put myself, there I am. Okay. So what I'm going to be doing is a very quick case, this will be a much faster pace. I've probably put a little bit too much content, and I encourage people to go ahead and sign off when you need to attend the primary care call, but I plan to end at 8 regardless. I've made sure there are no identifiers in the case. This is for educational purposes only. So the patient is a 50-ish-year-old man with obesity, hypertension, sleep apnea, and newly diagnosed diabetes. Like many of our COVID patients that we've seen, he does not have insurance because work was closed due to the pandemic. A brief case history. So he presented to the emergency room with a chief complaint of vomiting. He had other symptoms as listed here. In the emergency room, noted to have dry mucous membranes, an elevation above baseline creatinine, hazy opacities on chest x-ray, and what they considered adequate oxygen saturation. The COVID test returned positive at a later time, and I saw the patient as a virtual management patient with a chief complaint of abdominal pain, nausea, and vomiting. Other symptoms are as listed here. So the plan for that first visit was a trial of aggressive antiemetics, self-hydration. Follow-up is tier 3, meaning we were going to call twice a day. He was completing a Z-Pak from the primary care physician. We saw the patient the next morning, and the nurse called me and had me do a repeat video visit. He'd had a very restless night, not sleeping, mumbling and moaning. He was able to speak in the morning, but it was clear that outpatient management was not working, so we referred him to the emergency room. So in the emergency room, his chief complaint had not changed. He had no focal findings on the abdominal exam. They did a chest x-ray, which showed progression, and they did a CT of the abdomen without contrast, which showed ground glass opacities at the lung base, and interestingly, moderate retroperitoneal inflammatory changes. They noted that the labs were much worse, and they planned IV fluids, IV analgesia, and they admitted. The patient received 3 liters of fluid within the first day and a half. He had a urine output of 1 liter. So if you can see these are some of the basic labs. I have here on the far right the historical creatinine. Here is the initial creatinine at the first ER visit, and then here's the creatinine 48 hours later on the second ER visit. After he received IV fluids, here's a follow-up creatinine, again, 2 days later. The CBC was fairly unremarkable. This was stable from previous, no change in the ER with a normal differential. He was not hypotensive. He was borderline he was hypertensive and treated. And just to show, he did have some fevers. This was over the first couple of days of hospitalization, but not persistent severe fevers. And heart rate was slightly tachycardic and stable. The urinalysis, interestingly, this was the first ER presentation in the far right, then the second ER presentation, and then multiple repeats over the course of a 2-week hospital stay. And you see it was persistently proteinuric and microscopic hematuria. There was no urine electrolytes in the first few days, but he did have a low fractional excretion of sodium and a high protein creatinine ratio when it was checked on day 5 in the hospital. BNP was not elevated, and he was not in rhabdomyolysis. He did not receive IV contrast. He was not taking NSAIDs. So here's the CT. I just thought this was interesting. And again, I don't have a final diagnosis necessarily, but look at the retroperitoneal inflammation and the perinephric inflammation. So moving forward, I think we have a report. So they note just those two things I put in bold: moderate, predominantly retroperitoneal inflammation, bilateral perinephric stranding, non-specific. The renal ultrasound had similar findings. So edematous renal parenchyma with trace perinephric fluid. So the hospital course, actually fairly uneventful. He was treated for possible pyelonephritis, but the urine was sterile. He did have the azithromycin, not certain if that is related to this. He was intubated for 3 days for true hypoxemic respiratory failure. He self-extubated to high flow nasal cannula, and then he was transitioned to room air over 3 days. It was a total of a 2-week stay in the hospital for respiratory and renal complaints, and then he was discharged home. So looking at his creatinine over the course of the hospitalization, you see the initial ER was still double his baseline at 1.3, and here's his discharge creatinine, which really got my attention. I tried to look at other markers. I know people are watching D-dimer, so here it was at the 2,000 range in presentation, and then subsequently 1,200. The peak was 6,600 during his ICU time. CRP was elevated at 100 on presentation, peaked in the ICU 120 and came down nicely. It actually does sort of mirror the creatinine course in terms of the timing. So quick key points. What can I do in 4 minutes? Well, I wanted to point out that renal risk is high with COVID-19. This is very, let's call this emerging data. I think most of the publications over the last 1 to 2 weeks. Talk a little bit about follow-up because we're not caring for them in the hospital, but we see them after. And then I won't have time, but I'll share my slides. Is there direct viral involvement? A lot of interesting autopsy studies. I say a lot, several interesting studies. So first of all, AKI is really common. So initial reports had 0.5%. More recent in the US, it's 27 to actually getting close to 50% of hospitalized patients. The onset is in that feared second week. It manifests as elevated creatinine, but also proteinuria and hematuria. And each of these, elevated creatinine, hematuria, proteinuria, are all associated with hospital death. New York Experience, they have a preprint that shows AKI in 46% of hospitalized patients, and notably 44% that were discharged had residual acute kidney disease at discharge. There's possible mechanisms. Our patient did not have a lot of these, mostly hypovolemia, but you can imagine other causes in our hospitalized patient population. The Brigham and Women has a workup suggested. It's actually just the usual workup as I read through it for acute kidney injury in a hospitalized patient, but I put this slide in for reference. Same for management, but I wanted to highlight the ACE and ARB question because we've talked about it a lot for general COVID, but we haven't talked about it in the setting of AKI, and it is still important to assess and discontinue that. In terms of specific management, I like this quote from a recent review article: speculation about specific interventions would not be appropriate. So in terms of planned follow-up, I just wanted to make a suggestion. This is from the National Kidney Foundation, which is that patients who had significant AKI should have nephrology follow-up. So that's something to consider. And patients who had blood or protein in their urine. So look at these in your hospitalized discharge patients because they recommend monitoring them after discharge for development of chronic kidney disease. In the UK, the NICE recommends that you follow it for at least 2 to 3 years. And then for reference, I included the frequency of monitoring that they recommend in the next couple of slides, which is just to look at the clinical context at the time of discharge, the degree of kidney recovery, and then plan a follow-up either at 3 days for the highest risk, 1 to 2 weeks for the moderate risk, and 1 month for the low risk patients for kidney function. So these will be in the slides that I post. The last provocative question, is there direct viral involvement? I'm going to skip ahead and just show you the electron microscopy. This is podocytes, and you can see the virions in the podocytes. These are patients who presented with glomerular nephropathy. There's also similar studies showing in the tubules. Here is endoplasmic reticulum suggesting viral replication in the tubules. So very interesting, provocative stuff. With that, I'll end. Thank you, everybody, for your time this morning, and thanks to our guest speaker.